Hello and welcome to this lecture, which is the first lecture in the epidemiology section of the HSS1 course. This is an independent study module where, as you can tell from the title, I'm going to be covering study design, bias, and confounding. I am David Anthony. I'm a family physician and I'm the family medicine clerkship director, so you guys will all meet me in your third year, but of course you'll meet me also in your first year. And so let's dive right in. So we're going to go through a variety of study designs and spend a little bit more time on the observational study types, case reports, cross-sectional cohorts, and case controls. And then also talk briefly about randomized controlled trials. And then we're going to get into bias and talk about two different types of bias, selection bias and measurement bias, and give you a bunch of different examples of both. And then talk about the important idea of confounding. Okay, so getting right into it. Just to remember, we should start with the overall goal of epidemiology, which is to find associations between exposures and diseases. And just to be clear, we should really say outcomes. And so, because not all outcomes are bad, sometimes we actually might want to measure health as an outcome as opposed to a bad thing happening. And what we're really trying to find not just is associations, but causal associations, exposures that cause either diseases or exposures that cause good things. And so, classic examples, of course, was the discovery that tobacco is in fact a cause of lung cancer. Now, some risk factors or exposures are things that we actually don't have control over. So like tobacco, we can choose to be a smoker or not to some degree, but age, we cannot. We're all aging. But as it turns out, age as an intrinsic factor to all of us is in fact very strongly associated with basal cell carcinoma, which becomes much more common the older we get. And also just remember that some exposures can be other illnesses. So actually having the experience of contracting SARS-CoV-2 and getting COVID-19 illness actually places you at higher risk of developing this other illness, which is venous thromboembolism or a blood clot in your venous system. Okay, so exposures can be a wide range of things, and outcomes can be all quite different. And not all exposures are bad, because there's exposures like things like exercise, which might lead to health. So we might measure an outcome that's a good thing with certain exposures, certain treatments. And in randomized controlled trials, we're endlessly trying to figure out if certain treatments, some drug or some other approach to treatment, is better than some other approach. Or surgical techniques are a treatment, of course. And just to remember that, in fact, not all interventions that we do are, in fact, treatments. Sometimes there's tests, like a screening test is, in fact, an intervention. But we might want to figure out if having a screening test, say a mammogram, leads to better survival from breast cancer than those who do not get screening tests. So let's get into study tapes. Okay, so the observational study tapes are these 5, okay? And the first two, case reports and case series, really go together, and they're the most simple, because a case report is purely simply a description of a single case. It is a narrative explanation of what happened, and a case series is a grouping of cases with similar features to describe some phenomenon that people notice with a group with a cluster of patients. And this is really useful for new discoveries and new things. And a good recent example of this was the observation that patients who developed COVID-19 who were treated with this very effective treatment, nirmatrelvir ritonavir, which is under the brand name Paxlovid, which had been shown in studies to be a very effective treatment for COVID-19, a certain number of doctors started to notice that patients sometimes have a rebound illness after they finish their Paxlovid. So Paxlovid is a 5-day course of treatment, and that certain number of patients, their illness would go away, their test would turn negative, they'd feel better, and then several days after finishing the Paxlovid, they would start to feel sick again. And in fact, sometimes they started to test positive again. And the way we learned about this was through case series. And there was a nicely published case series published in the New England Journal just recently of about 19 or 20 or so cases that sort of showed that this is a new phenomenon for us to know about. And these types of studies tend to be important for new things, new discoveries, new findings, new drug interactions, for example. Some drug has been approved by the FDA, and now people start to notice that it actually tends to interact with some other drug or cause a particular side effect that didn't happen enough in the original trials that we could notice it, but now we see that it's happening. It might be important to publish that. And the important thing to know about case reports and case series is that they are purely non-experimental. There is no comparison group. They're just narrative. They're just explaining things that happened in the world. And again, they can be really important for new stuff to get doctors to understand. And I would just say to you that the COVID pandemic was just an incredible experience for all of us going through it de novo. And it was case reports that sort of got us to understand how this illness works and what it does and what it looks like, and gave us some initial inklings on how to treat it. Okay, moving on to the more meaty kinds of things. So experimental types of studies where we're actually doing hypothesis generation and thinking about different groups. So the first of these is a cross-sectional study. And a cross-sectional study, the highlight of this is that the exposure and the outcome are measured at the exact same time. Okay, so as an example, all survey research where you ask people a whole bunch of questions and you see if there's associations between their answers to question 9 and question 10, if there's any sort of patterns that exist among people who report that they smoke, and some other thing that they report on the same survey. There you're measuring the exposure of smoking and the other outcome that you're measuring on the same survey. You've measured them at the same time. And so that's cross-sectional. It's a snapshot in time of individual subjects in your trial. And what these studies end up being able to measure is, for one, the prevalence of an illness, how common an illness is in the population that you're studying at a given moment in time. We'll come back to prevalence and incidence a little bit more in a later lecture, but for now, cross-sectional studies, all they can do is measure prevalence and occasionally measures associations between certain exposures and certain outcomes. Now, the advantages is that they're fast and cheap. Takes 3 seconds. You just do a survey, ask a few questions, find your population, and boom, you get your answer. And so they're one of the more common types of studies that people do in med students, often because they are inexpensive and don't require a lot of time, which you don't have a lot of time as a med student. Often kind of research that med students are apt to do. But they have some pretty big disadvantages, and the biggest one is that the exposure that you measure does not clearly come before the outcome. Let's say you measure, smoke. So actually a good example that has been hotly argued about in the research, which is that we find frequently when you do studies around this, that people who have schizophrenia are much more likely to smoke tobacco than people who don't have schizophrenia. And people have wondered whether smoking is in fact a cause of schizophrenia. But there's also a reasonable theory anyway to conjecture that perhaps schizophrenia causes smoking. And I'll explain that, which is that actually there's been some theory anyway, and a modicum of evidence that suggests that actually smoking may mitigate some of the symptoms of schizophrenia, that some of the hallucinations are milder when people smoke cigarettes. And so that actually in that case, people who have schizophrenia actually might be more likely to start and continue smoking because they see some benefit from it that other people do not. That is, by the way, hotly argued. I don't want you to take that as take it to the bank as gospel truth, because people really argue whether schizophrenia leads to, or that actually smoking mitigates the symptoms of schizophrenia. That's not a clearly understood thing. But if you did a cross-sectional study of smoking and schizophrenics, you would find that association, but you would not be able to clearly show that smoking led to the schizophrenia or the other direction. We don't know. You'd need to do a study that follows people over time. And because of this, because the exposure and the outcome are measured at the same time, you really can't make conclusions about causes of outcomes. All you can do is make claims about associations between exposures and outcomes. And that's an important principle that might come up on a board's question, that cross-sectional studies, you cannot make conclusions about cause. Okay, but to get closer to cause, we get to more elaborate studies, like, for example, the cohort trial. Now, a cohort study, the basic methodology is this. You study a group of people, otherwise known as a cohort, which is really a synonym for the word group, and you follow them over time. And you start with your cohort, your group, and your subjects who comprise your cohort are chosen on the basis of being people who have the potential to develop the outcome of interest. And what that means is they have the right organs to develop the outcomes. For example, if we're looking at prostate cancer, you'd need to only study people who have a prostate to figure out who could get prostate cancer. But also, you have to start with people who actually don't have the outcome already. So in my example of risk factors for prostate cancer, you'd want to take people who have a prostate who don't have prostate cancer when you enroll them in the trial. Okay, so you get your group who could potentially have your outcome of interest, and then you measure their exposure status at the baseline and when you enroll them in the trial. And sometimes you might come back and measure their exposure status a few times because sometimes exposures come and go, like smoking, for example. But people might smoke for a while and then quit, or vice versa. So you might have to, if your trial is long enough, measure exposure status several times. But you're trying to measure exposure status before people then develop the disease. And then you follow those subjects and see who gets the outcome over time. And that might be a long period of time. In a trial for prostate cancer, you'd have to follow patients for quite a while to see who ends up getting a diagnosis of prostate cancer. And there's a varieties of ways of measuring outcomes. You can just do chart review. If it's a group of patients for whom you have their electronic medical records, you could see over time who eventually gets the diagnosis added to their chart. A more elaborate and actually better way to do this that's more involves more person time is to do serial interviews with your subjects, to, like, say, every 6 months, call them up or bring them in and have do a physical exam and ask them a bunch of questions, and then confirm who has a diagnosis and who does not. If death is your outcome, you can just simply look at the death registry and see who has died and who hasn't. So there's, again, a variety of ways of looking at outcomes. But the key is that you're following the outcomes over time, starting with people who don't have the outcome at baseline. And the advantages of a cohort study are they're really good for measuring the incidence of a disease. And again, we'll talk about this more in a future lecture, but incidence is the rate of development of new cases of a disease. In a cross-sectional study, you can't measure that. You just figure out who has the disease right now. Incidence you can measure only from a prospective trial, like a cohort trial where you're moving forward in time. And one of the advantages, because you're measuring people prospectively, is you can actually accurately measure people's risks of developing the illness. And we'll come back to this again more in the future, but it allows you to measure as an outcome a relative risk, or risk ratio, which is another name for the same thing, both abbreviated RR. And that is really the ideal outcome that we really want to see in trying to figure out if things are associated or causally associated with an outcome. And you can measure a whole bunch of exposures at baseline. You don't have to just measure one thing. If you find people who don't have the disease that you're interested in or the outcome you're interested in, you can measure, smoking status, zip code, age, a whole, whether they take certain drugs and whether they eat a high-fat diet or a low-fat diet. A whole range of things can be measured at baseline. So you can fairly efficiently find a whole range of things associated with an outcome. And the classic example of this is the Framingham Heart Study, one of the most important epidemiologic cohort studies we ever did, which was started in 1950. And it is really from that trial that we figured out that hypertension is associated with heart disease, and that diabetes is a cause of heart disease, and that high cholesterol is a cause of heart disease, and that smoking is a cause of heart disease, because we measured all those exposures at baseline and followed people. And in a range of other things, sedentary lifestyle, truncal obesity, whole range of things that are associated with cardiovascular disease, all figured out from just one very large cohort study. And in general, they are good for common outcomes. This is both a strength and a weakness, as we'll come back to in a minute, which is that we tend to use cohort trials when we're looking at outcomes that are fairly likely to happen in your population of interest. So you can have enough outcomes to show a difference between your different exposure arms of your trial. So example, like I just mentioned, was the cardiovascular disease, so hypertension, smoking, and lipids, and their impact on heart attack and stroke. Well, heart attacks and strokes are very common. The leading cause of death is heart attack. So you can find enough people who have that. And so in a cohort, you can trust that you follow them long enough people are going to develop that outcome. Same with things like breast cancer, pancreatic cancer, common enough cancers. You can find risk factors and causes for those through cohort studies. Now, the disadvantages are, for one, that they're very slow and tend to be very expensive, because you have to follow people forward in time to see who gets the outcome. And if the outcome is something that happens slowly and episodically, that might take years. And the Framingham Heart Study actually was started in 1950 and wasn't actually closed until after the year 2000. They followed some people for more than 50 years, believe it or not. Now, they are really bad for rare outcomes. And as an example, I will tell you that I have a patient in my clinic who has a condition called stiff person syndrome. That is a very rare illness that happens in about 1 in 500,000 people. And the population of Rhode Island is just over 1 million. So on average, you'd expect that in Rhode Island we'd have about 2 people who have stiff person syndrome. If we wanted to do a cohort study to look at risk factors that lead to the development of stiff person syndrome, and if I studied the entire population of the state of Rhode Island, which would be a very cumbersome and hard cohort study to do, and followed people over years, I would only find 2 cases on average. And that's not enough people for me to make any true conclusions about causes, because our statistical power would be terrible. And importantly, all observational studies, cohort study or any of the other observational studies, are beset with this important problem, which we'll come back to at the end of the lecture, called confounding. But I want you to remember this. Cohort studies really struggle with confounding. Okay, and this is what the 2x2 table would look like for a cohort study. And this is sort of a standard way of presenting the results. And let's say I'm looking at, I'm interested in vitamin D supplementation, who takes vitamin D pills, and who gets osteoporotic fractures from thinning of the bones. And let's say I take a cohort of 205 people without osteoporotic fractures, and I measure who takes vitamin D and who doesn't take vitamin D. And I find that I end up with 105 people who take vitamin D at baseline and 100 people who do not. And I find that there's 35 people who have a fracture in the vitamin D arm and 60 who have a fracture in the no vitamin D arm of my trial. And if I want to measure, just to give you a little preview, if I want to measure the risk of having osteoporotic fracture in my exposed arm, well, that's in the vitamin D arm. And I find that I have 35 people who had the outcome out of the 105 people who could have had the outcome, who had the potential to develop a fracture. So it's 35 out of 105, or 35 divided by 105, which gives you 0.33 as your risk in that group. And then the risk in the people who don't take vitamin D is 60 out of the 100 people who weren't taking vitamin D at baseline. So that's 0.6. And then to find the relative risk, which again we can find from a cohort trial, you just take the ratio of risks. So the risk in one arm divided by the risk in the other arm. And by convention, we tend to put the exposed group in the numerator. So our exposure here is vitamin D. So we would put vitamin D up top and find that the relative risk of having a fracture if you take vitamin D is 0.55, or you have a 45% reduction in your risk of an osteoporotic fracture if you take vitamin D, according to this cohort study. Okay, I made up these data, but they are somewhat analogous to data that actually have been observed in observational studies of vitamin D supplementation and fractures, which make vitamin D look really great. But we will come back to that a little later. Now, let's move on to case control trials. So this is a really important kind of study design that is often misunderstood and poo-pooed by people who I think tend to misunderstand it. It can be incredibly powerful, and I'll explain why in a minute. But the idea of a case control trial is that you start with a collection of cases. So you start at the end. You start with the people who have the outcome already that you're interested in. Okay? And then you find your cases, and for each case, you match each subject who is a case with a control, or perhaps more than one control. You don't always match at a 1-to-1 ratio. You might match at a 1-to-2 ratio, or even a 1-to-10 ratio, where you find 10 controls for every case. It doesn't matter. Having more controls is more work, but it gives you much more statistical power. So it's beneficial to add more and more controls to your trial. And you can match them on a variety of exposures. If I was looking at vitamin D and osteoporotic fracture, I might want to find people who had a fracture, but I would find then people who didn't have a fracture, but I might match them, say, on age and on sex. So I might find, if I had an 84-year-old female who had a fracture, I might then find an 84-year-old female who did not have a fracture, okay, as a matched control. Okay, and then you measure your exposure status in both groups. So you figure out who among the cases was exposed and who among the controls was exposed. And really you're trying to look back to see who was exposed, hopefully before developing the outcome. And again, it's only the cases who develop the outcome. The controls didn't ever get the outcome. So your cases are people where you're trying to see if they were exposed. So for are people with osteoporotic fracture, I'd be trying to ask them if they did take vitamin D before they had the fracture. And then the people who don't have a fracture, ask them if they have been taking vitamin D in the same time period, for example. And a really key point about a case control study is that you start with cases. So the way to identify it is that you start with cases at the beginning, and you hand match them to controls. Okay, so and again, often matching on a variety of potential confounders. Okay, so the advantages of case control trials is that they're really good, unlike cohorts, they're really good for rare outcomes. So I could take stiff person syndrome, and there is in fact a stiff person syndrome clinic at Johns Hopkins University. It's the only one in the country. But let's say they have 200 patients with stiff person syndrome. Well, you could find those 200 people and match them 10 to 1 with 2,000 people who don't have stiff person syndrome, and do a bunch of research on possible exposures that lead to be risk factors for developing stiff person syndrome. Okay, but you couldn't do a cohort trial to figure that out. And then, as it turns out, this phenomenon of matching is an incredibly efficient way to address confounding. We'll come back to that later, but it's really important to remember this is the best way to address confounding that we have in observational studies. Okay. And they're fast because you start with people who've already developed the outcome. You don't have to wait and follow over time to see who does develop the outcome. They've already had it, and then you can just retrospectively ask back and see what happened in terms of their exposure. So it takes a lot less time to do case control trials than cohort studies. And because of that, they're much less expensive. And you're dealing with smaller numbers of people, and you're looking back in time rather than forward. So they just cost a whole lot less. So you can get answers relatively quickly and very efficiently deal with confounding. Now, they do have important disadvantages. Now, the biggest one is this, that how you find your controls is tricky. And this is beyond the scope of this class here, but really you have to put a lot of thought into where you find your controls, because you want to make sure that your controls are arising from the exact same population from which your cases arose. And doing that accurately without bias is tricky. The other phenomenon is this phenomenon of recall bias. We'll come back to recall bias a little bit later in more detail, but because you're asking people to remember things that happened beforehand, often there can be different ways that people remember things depending on whether they're a case or a control. And remember, even though you've dealt with some confounding with your matching, there always still is residual confounding, because this is an observational study, and all observational studies are beset with confounding. And the last thing is important, actually, is that the outcome that you can measure from a case control trial is not risk. You cannot assess the risk of a disease. All you can assess is the odds of a disease and the odds ratio. So you can't get a relative risk, which I told you before is the optimal measure of outcomes, is relative risks, and you really only get relative odds from case control studies. And let me show you that a little bit here. So here I have my 2x2 table that we had before. And so now I want you to imagine a case control study that actually was done. I've made up these numbers, but this is based off of a real example, looking at Zika infection in pregnancy and the development of an infant with microcephaly. So microcephaly is the birth of a newborn who has an underdeveloped, very small cranium, which leads to severe intellectual disability often. As it turns out, people started to notice that this infection, the Zika virus, which spread around the planet about 10 years ago, was leading to what appeared to be a higher rate of infants born with microcephaly. And they weren't sure that was true, that it really was a cause. So one of the first things people did was a case-controlled study. So you would find infants born with microcephaly, which is a fairly rare outcome, so ideal for case-controlled trials. And then you'd find for each case, say you would find matched controls. So let's say you have 100 infants born with microcephaly. So then let's say you find 200 who don't have microcephaly. So those are your controls. And you might, for example, in this case, match them on the gestational age at which they were born. And you could also match them on the age of the mother at the time of delivery, because maybe maternal age is a risk factor for microcephaly, and gestational age could be too. And so you could match on those two things, but the exposure you're interested in is, did the mother experience Zika virus infection during pregnancy? And so you'd have to somehow go back and figure out if the children who were born with microcephaly, if their mothers had Zika infection, and then similarly the controls, if their mothers had Zika infection. So here I've got my 2x2 table where you've got 80 infants born with microcephaly whose mothers had Zika and 20 who didn't. And then 40 who didn't have microcephaly who had Zika, and 160 who didn't. Again, I've made up these numbers a little bit. But I want you to remember in my last table, my 2x2 table of the cohort trial, the way I measured risk was to go across. I would look at the Zika arm, the exposed arm, and look at all of the people who could potentially have had the outcome and divide that by the people who did in fact have the outcome. So I would have taken 120, I would have taken 80 people who had microcephaly and divided it by 120, because that's the sum of those two rows. But you can't do that in a case control trial, because this is not the entire population of people who got microcephaly. Remember, I've just found a few cases, and then I hand matched a few controls. I could have matched 10 to 1, I could have matched 5 to 1, I could have matched 4 to 1 or 1 to 1, and I'd have different numbers in that right-hand marginal area where I have 120. And so you have to imagine that there's a solid line or a double line between my cases arm and my control arm, and you cannot add the numbers across from right to left in this if you've set up your table this way, because this doesn't represent the entire population. And that's an important principle. So I have to measure this other thing, which is called odds. And odds is simply the ratio of people who have either the exposure or the outcome of interest to those who do not. So you're not taking the sum, you're not taking the ratio of those who have it to the marginal value of all the people who could have it. You're taking it those who do ratio to those who do not. So as an example, the odds of being exposed among the cases in this study, of my made-up study, is 80 to 20. There were 80 people who had Zika, prenatally, and 20 who did not. So you have an odds of 80 over 20, okay? And the odds of being exposed among those who do not have microcephaly is 40 over 160. Again, I'm not dividing 40 by 200, which is the marginal value. I'm dividing it by the group who did not. Okay, so odds all exists within the confines of the table, where risks involve the marginal values outside of the table. Okay, that's really important. And so all I can do is measure an odds ratio, and I'll come back to odds ratios in a future lecture, but important to remember, case control studies, all you can do is measure odds. Now, a brief note on another concept in observational studies and randomized trials, which is the idea of prospective versus retrospective studies. And I think this is an overblown distinction that people get head up about. But just in general, the general rules about this is that, for one, cross-sectional studies are neither retrospective or prospective, because remember, they're just a flash, a snapshot in time of a single moment where you measure the exposure and the outcome at the same time. So there's no time feature at all to a cross-sectional study. Case control studies are generally inherently retrospective, in that you start from the end. You start at which the point people have the cases, and you go back and you see what happened beforehand. But I can give you an example in a minute where it's not entirely retrospective, so we'll come back to that in a moment. And cohorts are typically prospective. Again, you start with people who don't have the illness first, and you follow them forward in time. So usually they are going forward. You can do a retrospective cohort. You can take a database of patients that already exists, of where events have already happened, and you can find all the exposed people, the people who had the exposure 10 years ago, looking at this database, and then see who developed the outcome. And the data were collected prospectively, but you're looking back in time retrospectively. So again, this is where this distinction is a little bit fuzzy. The case control version, you can also do a case control study, again, where the data were collected prospectively. You have a data set and you find some cases and you hand match controls to those cases and you look back and see who was exposed and who was not in data that were collected in real time prospectively at the time. Is that a retrospective study or a prospective study? I'm not entirely sure. But on a board's question, a case control study is going to be a retrospective trial. Cohorts are generally prospective. And all randomized controlled trials are inherently prospective because we start with patients, we randomize them to get an exposure or not, and we follow them forward in time, and they are never retrospective. Okay? And that brings us to randomized controlled trials, which in some ways is the simplest kind of trial to study or to explain, because really a randomized controlled trial is just a cohort. It's a cohort study, but where we've picked who gets exposed and who does not. And it's the gold standard for determining if an intervention is beneficial. And this is the kind of evidence that we need to prove whether some intervention is something that we should be doing in people because it helps people. So again, as I said a moment ago, it's really identical to a prospective cohort, but the exposure status is determined randomly by us, by the researchers. We don't let nature or patients pick whether they're exposed or not. And the general process is this. You identify the intervention, the outcome, and the population you want to study. So you have a research question, a PICO question, to say, does this treatment lead to better outcomes in patients who look like this? So once you've done that, you then find your subjects, who are the patients who look like this, whatever your enrollment criteria are, and you obtain informed consent. And this is important. You do this before you do the randomization. You have to ask people if they want to be in the trial. You discuss the risks and benefits to them of being in the trial. And then if they agree to be in the trial, then you randomize them. You can't do the randomization first. So then you randomize through any of a variety of processes, but usually using a computer, you randomly assign people to whichever arm of the trial you have. And you might have 2 or 3 or 4 arms depending on the trial, but most commonly there would be 2 arms, some treatment versus a placebo or some treatment versus another treatment, that sort of thing. And then, just like in your cohort trial, you follow people over time and see who develops the outcome, using all the same measurement techniques you might have used in a cohort trial to assess outcomes over time. And just remember, it is randomization, randomly assigning people to one exposure group or the other, that is the secret sauce, and it must not be altered. And that's important. That leads to this idea of the intent to treat principle, which is a fundamental and important principle in all randomized controlled trials, which is that you have to analyze subjects in an RCT in the arm to which they were randomized, not the arm to which they ultimately went. Because in randomized trials, people don't always get what they're supposed to. Unless, as an example, imagine that I want to see if physical therapy is good for low back pain, common lumbosacral strain. That's common presentation in primary care, and I want to know is physical therapy better than just taking ibuprofen for low back pain. So I could randomize people to get physical therapy, 10 visits over 10 weeks, or just take Motrin for the 10 weeks. And as it turns out, some people randomized to the physical therapy might not actually get it. They might go to one visit and decide, I'm all set with this, and not go to any more visits. Or other patients actually might be likely to not go to physical therapy for reasons that end up biasing our results. For example, patients who don't have a car might be less likely to go to physical therapy because they can't afford to get there, a legitimate reason to not go. And so as it turns out, if we let people choose which arm they go to, that happens in non-random ways. So we might find that the patients who don't get PT are systematically different from the people who do, which leads to a bias in our measurement. And so, or it actually ends up to confounding of our measurement of the effect of our treatment. And so it's important, even though it seems counterintuitive, if we know a subject was randomized to get physical therapy and we know that they didn't get it, we have to consider that person a physical therapy patient when we measure the outcomes and when we measure the effect of the intervention on our outcome, even though that feels wrong. But that's an important fundamental principle of randomized controlled trials, which is again called the intent to treat principle. And now moving on, the advantages of randomized controlled trials. The most important one is that unlike any other study design, they effectively eliminate confounding. And again, I'll come back to confounding in a minute. But that is why we do randomized controlled trials, because we get rid of the problem of residual confounding and can purely assess the impact of just one exposure on the outcome. And because they're prospective like a cohort, we again are able to measure relative risks and get risk ratios, and so that these are the kinds of outcomes that are the most meaningful in assessing whether something really works or not, or causes an illness. And it is the only study design that allows us to determine if an intervention is effective, is causally related to a good outcome. Okay, so it's the gold standard. It's the kind of research we need to do if we want to prove that something works. Now, the disadvantages also pretty significant. One, they're very costly and they can be very time-consuming, especially if we're looking at an intervention that unfolds over a long period of time, like, for example, taking pills for blood pressure and preventing heart attacks. It's not like you take a pill one day and you prevent a heart attack tomorrow. You have to take them for years sometimes to prevent heart attacks. So you have to follow people for a really long time. And you have to think about the ethics of randomized controlled trials, because we're intervening in people's lives in an important way. It is never ethical to randomize patients to get less than the standard of care. So you have to know that you're randomizing them to something we don't know if it works, and the people who aren't getting that, but we want to know if it works. And then the people who aren't getting that new experimental thing, they're at least getting the standard of care that exists currently. And there has to be a legitimate question that we don't know the answer to before we would subject people to being randomized to get one thing or another. Another disadvantage is that they tend to be, by their nature, very reductionist, meaning we study a very narrow conclusion in a narrow population because all we're looking at is one exposure done one way in one group of patients identified by a certain set of inclusion and exclusion criteria. And we have to be careful about not extending the conclusions from a randomized controlled trial to populations who would not have been able to be enrolled in that trial in the first place. And so you often have to do multiple randomized controlled trials to assess whether something works in multiple populations. And just as an example, the rollout of the COVID-19 vaccines, we started with studies in adults. And then slowly we've been adding randomized controlled trials of the COVID vaccines in people 12 years and up, and then moving from there down to 5 years and up, and finally getting to research done in people 6 months and up. And so it's taken quite a long period of time to show that the COVID-19 vaccine is safe and effective in infants and young children. Okay, and let's just go through a few examples of research studies to see if they what they are. So these are the kinds of imaginary studies that you could imagine might show up in a board's question. So here's one. So researchers are interested in the relationship between cycling as a sport, like riding a bike, and head trauma. And they identified 2,560 subjects from a community clinic and determined from an intake interview whether they cycle for exercise or transportation. And then over 5 years, they identify, following those patients, 288 of individuals who have head trauma. And these they call their cases. And then there were 824 cyclists at baseline, 40 of whom had head trauma. And among the 1,736 non-cyclists, 48 had head trauma. And the question is, what kind of a study is this? And as it turns out, importantly, this is a cohort trial. And I threw a curveball in there by saying that these they call their cases. And that's the sort of thing that might show up in a board's question, that they sort of use some terminology that leads you down one garden path. But you can tell this is a cohort because they started with patients at baseline who didn't have head trauma. They measured their exposure status at baseline, and they followed them over 5 years forward. And over those 5 years, they found a certain number of people who developed head trauma. So the exposure happened first. They found people who didn't have the disease at first, and they followed them forward. And it doesn't matter what they call them. If they call them their cases, they could call them their best friends, but it doesn't really matter. It doesn't matter. This isn't a case control trial just because they called them cases. Okay, and remember, and so then asking what kind of outcome can be determined from this kind of study. Well, here you could measure the incidence of head trauma, so you can measure incidence rates, and then you can measure relative risks from a cohort trial because it's prospective. Okay, example number 2. Researchers are interested in the link between loneliness and symptoms of depression. So they identify subjects presenting to their primary care providers and, after obtaining informed consent, assess their level of loneliness using a validated scale. And for each subject, they then identify from the progress note from that day if the patient also presented with symptoms of depression when they actually talk to their doctor. And over the 3 years, they enroll 865 subjects, 120 of whom are identified as having loneliness, and of those, 31% presented with symptoms of depression, and among those without loneliness, only 24% presented with depressive symptoms. And what kind of study is this? This is a cross-sectional study. And the curveball here is that I told you that it took 3 years, that they followed people, that they enrolled people over 3 years. So it took 3 years to find 865 subjects. I don't know why it would take that long, but I made it up that way. But it doesn't matter how long the study takes from beginning to end. What matters for a cross-sectional study is that you measured exposure and disease at the same time. And here they did. They measured loneliness, and then they looked at the note from that same day and looked to see if they presented with symptoms of depression. So you don't know if the depression is the cause of the loneliness or if the loneliness is the cause of the depression. But you might find, as we did here, that there was an association between them. Okay, so the outcome that you can measure from this is prevalence. All you can measure is the prevalence of depression and the prevalence of loneliness among people who are presenting with depression. And you can't make causal associations between loneliness and depression at all. Our last example is researchers are interested in the link between environmental lead exposure and the development of neuroblastoma. They use data from the Framingham Heart Study, a large cohort trial. And among the many subjects in that trial, they identified 27 who did develop neuroblastoma. And for each of those 27 people, they identified 10 age and sex-matched individuals who did not have neuroblastoma. They measured their baseline lead levels from blood collected at entry into the trial, and they measured the association. And this is a case-controlled trial. And as an example, this is actually a nice example of what's called a nested case-controlled trial, because they found all of the cases as they arose from an actual cohort. So it's a case-controlled trial within a cohort trial, which is a particularly effective way of doing this if you have a large database that does identify a few rare outcomes. You can then do a case-controlled trial from the people who were in that cohort. But it is, in fact, a case-controlled trial. This is, again, called a nested case-controlled trial. And the outcome that you can measure from a case-controlled trial are odds and odds ratios. All right, those are our study designs that I want to talk about. Let's talk about bias. So bias is a systematic problem in a study that leads to mismeasurement and an incorrect conclusion. So things to remember, it's systematic, it's built into the way the study is structured, and it leads to an inaccurate assessment and wrong conclusion. And there are two main types. There's selection bias and measurement bias, and we're going to go through them each in some detail. So selection bias, I'm going to give you a wide range of examples of types of selection bias, is where the way in which we've somehow found our subjects to be in our trial leads to incorrect conclusions. And the most common of this is just simply sampling bias, which is that our study sample that we included is not representative of the population that we're really interested in. And so we end up finding an association that either is or that should or shouldn't actually be there in the population we're really interested in. And an example of this that came from randomized controlled trials is remdesivir, which is an antiviral drug for the treatment of COVID-19. And the story here is that remdesivir is this antiviral drug that when the COVID-19 outbreak, people started studying whether it worked. And the original randomized controlled trials were done in the hospital setting because it's a 5-day IV infusion, and it's hard to do in the outpatient setting. So they took people who were admitted to the hospital with COVID-19, randomized them to get remdesivir or not, and they found that it worked, but it only worked a tiny, tiny bit. So doctors were not very excited about this treatment. As it turns out, remdesivir is an incredibly effective treatment if given in the first 5 days of the illness of COVID-19. As it turns out, patients don't tend to end up in the hospital until about day 7 to 10 after they started their illness. And so we were studying the wrong population, because when someone had the right idea to do a randomized controlled trial of remdesivir in the outpatient setting, people presenting to their primary care doctor with COVID-19 infection who had not yet gotten sick enough to end up in the hospital, it turns out it's incredibly effective at preventing people from progressing to need hospitalization. So that was just a sampling bias. We studied the wrong population and almost missed that this drug works. Another example is antibiotics for sinusitis. There were a number of studies early on, a number of years ago, were done in patients who were presented with symptoms of sinusitis and then had a CAT scan to see if they actually had CAT scan evidence of sinusitis. And they took those patients who had CAT scan evidence of sinusitis and randomized them to get antibiotics or not. And sure enough, the antibiotics work like a charm. They really help people recover more quickly. But the problem is that in real primary care, in the real world of urgent care and ERs and primary care doctors, who are the people who tend to diagnose sinusitis, no one does a CAT scan to figure it out. So the population of patients that we really want to be interested in are the people that doctors assess as having sinusitis based off of clinical diagnosis skills, which is how we really diagnose it. And as it turns out, in that population of patients, antibiotics still work, but not very well. Actually, they work just minimally. And so again, if we select the wrong group of patients to identify in our trial, we can lead to the wrong conclusions. Now, there's a very special case of selection bias with case control studies, which is that we are hand-picking our controls, remember? So we are very actively selecting who's in our trial. And that's, you could do a whole course on how you pick controls for a case-controlled trial. But you have to make sure that you're trying to get controls that come from the population from which the cases came, and that can be hard to do. There's selection bias that comes from follow-up. So people in trials are lost to follow-up for a variety of reasons. They drop out of trials because they move away or whatnot. And this is also, by the way, called attrition bias. But loss to follow-up can happen because actually people have the outcome of interest. It might be that they got sick and died of the outcome of interest. And if the researchers aren't actively looking to find people, they might just think that subject 24 just sort of dropped off the face of the earth, and they lose them, so they exclude them from the trial. But they missed the fact that actually they died of the illness that they were interested in. And that might lead to missing an important discovery that people are dying of your illness that you wanted to know about. And sometimes those who are lost to follow-up are systematically different from those who are not lost. And so you lead to loss of important information and a bias. Non-response bias is a related phenomenon, which is that the people who decide to actually be in a trial, who agree to sign up for a trial, might be qualitatively different from the people who don't. And a classic example of this that comes from outside of the medical world are political polls. So you might remember that in the year that Donald Trump was elected to be president, the polls leading up to his election very clearly showed that Hillary Clinton had a big lead and was very much predicted to win that election. But as it turns out, in hindsight, of course, we know that she didn't win the election, that President Trump did win the election, and that people were not responding to polls who were likely to vote for him. That actually being a Trump supporter meant that you were actually less likely to pick up the phone and respond to a political survey done by telephone. And so they had the weighting all wrong, which led to an incorrect assessment in advance. And you could find examples like this in other survey research, again, in medical research, the people who sign up for a trial. Let's say you're enrolling people by having ads in magazines and on the radio, encouraging people to sign up for some study on smoking cessation. Well, you're only going to get people who read magazines and listen to the radio, which means you're going to miss all the people who find their information through Facebook and other online media. And so you have to think about, gosh, am I enrolling the wrong people? Am I going to get a biased sample from my process of getting people to enroll? Okay, so let's move on now to a special case of length bias. So length bias is a bias that happens in which patients with more severe disease tend to not get studied. So the people who have very aggressive illness that progresses rapidly onto death or to the outcome of interest tend to not even make it into trials. Again, often because they have died. So survival from breast cancer, that not all breast cancers are the same. So if people who have really aggressive breast cancer tend to not make it into the trials of looking at risk factors for survival from breast cancer, which leads to overestimates of survival because we're ending up with a group of people who tend to be less sick. And this has a particular impact on screening tests. Studies of whether mammography, for example, just picking on breast cancer, studies that looking at observational studies of breast cancer screening, the people who are diagnosed through screening rather than through the development of symptoms tend to have much milder illness than people who actually presented with a breast lump or with metastatic disease like bone pain or coughing up blood. Those patients are much more likely to have a very aggressive cancer. And so comparing people who are diagnosed through screening to those who are diagnosed through symptoms is comparing apples to oranges. And it leads to the perception, in this case, a bias that shows that screening is very effective. And often, by the way, actually leads to the true public perception that screening for breast cancer is very, very effective, whereas it is effective, but just less so than most people think it is. And there's a special form of length bias, which is this idea of survivor treatment selection bias, which is also a related phenomenon, which is that only those, if we're looking at a treatment and whether it leads to good benefits, we look at observational studies of some treatment of patients who got the treatment versus those who didn't. As it turns out, only those who've survived long enough are offered the treatment compared to those who don't. So the people with a really aggressive illness tend to not get the treatment in the first place. So, for example, surgery. Surgery is often held out as a last resort. So we try physical therapy and we try these other conservative measures, and it's only those who actually who make it through those and don't have benefit who we end up operating on. But not only do they have to make it through those things and not have benefit from those things, but they also have to have survived long enough to make it to the surgery. So we tend to operate in those examples, in this hypothetical example, on people who have milder disease, for whom it makes it look like the intervention is very effective. And again, this is when we're doing things observationally, where we're letting doctors decide who gets the treatment and who doesn't, rather than doing things randomly. Okay, so let's shift now away from selection bias to measurement bias. So this is the other type of bias, which is in how we measure things. So you can measure either the exposure status or the outcome status incorrectly, and that happens, mismeasurement of both things happen. And the important distinction you need to figure out with bias, is it differential bias or non-differential? And differential bias means that the mismeasurement is happening differently in the two arms. Like being exposed leads to one rate of mismeasurement, and being unexposed leads to a different rate of mismeasurement. Okay? And that's important. So non-differential mismeasurement always happens. It's always present because whatever our assessment is, our tool that we're using to assess exposure status or assess disease status, no tool is perfect. So we will be inaccurate a certain percentage of the time. But if it's non-differential, if it's happening at the same rate in both arms, that matters less. It's less of a concern in epidemiologic research. But when there's a differential misclassification where it's different between the two arms, that leads to very biased measurements and wrong conclusions all the time. So let's give some examples. So the first one is a weird one, which is actually faulty randomization, which is not so much that we're mismeasuring the exposure status, but we're not actually accurately randomly assigning people to exposure status. And you'd be amazed at how easy it is to mess up randomization. It seems kind of simple, but remember, randomization is the secret sauce of randomized trials. That is the magic. And if you mess up randomization, you can lead to bias. So an example of this is block randomization. A frequent thing in randomized trials is that we randomize people in blocks, sometimes called permuted blocks. And what that means is, let's say we're going to enroll 3,000 people in our trial and randomize them to a drug or a placebo. We often will do a thing where we say that every 10 subjects that we enroll, we know that we will have 5 placebo people and 5 people getting the study drug. And what that means, the reason we do that is that if we stop the trial at any point, we know that we'll have roughly 50% in each arm, because we know that after every 10, it's 50-50. And that makes a certain amount of sense and can be useful to do blocks. The problem is that if you have a savvy, well-meaning research assistant who's counting, paying attention to where they are in the block, and they're enrolling patients one by one, and they've noticed that they've just enrolled 5 people to the placebo and they've done 4 people to the treatment, they know that the next person is going to get treatment. Okay? And sometimes in being well-meaning and thinking about their patients, they might actively not enroll someone. Let's say you have a person, they have this new drug and they're excited to see if it works for this illness, and you have a person who comes in who's really quite sick with the illness, and you really want this person to get the new study drug, but they know that because they're following the blocks, they know that the next person enrolled is going to be a placebo patient. Well, they might sort of subtly figure out a way to get that person to not get enrolled today and come back tomorrow when someone has been enrolled and you've now gotten that person to get their placebo enrollment, and the next person comes in could get either placebo or intervention. And remember that once you allow doctors or research assistants or patients to pick what arm they go to, that's not random, and you've lost the magic of the randomized controlled trial. Now, getting more into pure misclassification, let's talk about misclassification of exposure status. This is a particular issue with case control trials. Remember, we start with cases and controls, and we're measuring exposure status retrospectively. And as it turns out, there's this particular issue with what's called recall bias, which is that our memory of exposure can be affected by being a case or by being a control. And our accuracy in remembering whether we were exposed or not. Let's make a hypothetical example. Let's see if I want to study whether adequate sleep on the night before taking USMLE Step 1 exam, which you guys are all going to take, is associated with passing USMLE. Now remember, vast majority of students do pass Step 1, but a certain percentage every year don't. And by the way, if you are someone who doesn't pass it, don't worry. That's something students live on from and can bounce back from. But obviously, if you fail Step 1, that would be an upsetting moment. And when you get your failing score, the natural thing for someone to do is to rack their brain and think, oh my God, what happened? Why did I fail? And remember all of the things that led up to their taking of the test. And their memory of their sleep the night before the test is likely to be influenced by the fact that they failed. So in a case control trial, where you take our cases are people who failed and we match them to controls who did not fail. Our controls, when we ask them, how did you sleep the night before the exam? Well, it's hard for those people to remember. And they're perhaps just more likely to say, yeah, I slept fine. And so you might find an association between inadequate sleep that's spurious. It's just purely influenced by people's altered memories. That's just one example, but you could come up with all kinds of examples where being a case alters your memory of events in a very significant way. And this doesn't have to be the patient who's remembering things. This can happen from interviewers. So an interviewer who's unblinded, a research assistant who's trying to figure out if the patient was exposed or not, might be, if they know this person's a case, might ask a lot more probing types of questions than when they're asking the control. Again, well-meaning assistants just doing their best if they're not blinded. So you have to try to make sure that interviewers tend to be blinded. Okay, so let's move on to misclassification of outcomes. And remember, there's always some degree of non-differential misclassification of the outcome, but what we're worried about here is differential misclassification. And so in cohort studies, one thing that can happen is that the exposure status can affect the way outcomes are determined. As an example, let's imagine we're studying whether being insured is a benefit or a harm in leading to a particular outcome. So we're comparing uninsured to insured people. Well, if the outcome is a diagnosis of some sort, people who have insurance are much more likely to go to the doctor and actually much more likely to get the diagnosis made compared to people who are uninsured. So it can bias us to show that actually being insured might make you more likely to seem to have the outcome of interest than the uninsured patients. And that's because we're measuring it differently in the two arms. And an important one in cohort studies is when the outcomes assessor is unblinded. whoever it is who's determining whether the outcome happens or not, if they know that the person is exposed or unexposed, they might be more likely to find the outcome in one way or another, ask the right questions and probe and look a little bit more to find out if the person has the outcome of interest. Now, this also can happen in randomized controlled trials, and again, it has to do with the outcomes assessor. So remember, blinding of the outcomes assessor is really important whenever possible, but it's not always possible. So we have people randomized to one arm or another, and the goal is to have the whoever is assessing the outcome not know if the person was a study drug person or a placebo person. But in certain cases, the patient, for example, might be the outcome assessor. The subjects, if the outcome we're looking at are symptoms, we have to ask the patient their symptoms using some symptom score. So as a real world example, looking at degenerative meniscal tears, which are a kind of tear that happens in the cartilage in your knee. And there were studies where people were randomized to either get arthroscopic knee surgery to fix that, or were just randomized to get physical therapy. And then they measured symptom scores. And it's hard. You can't blind patients very easily to whether they've had surgery. In the original trials, they didn't blind people because they just were told, well, you get surgery and you get physical therapy. And they asked people how they were doing over the next 3 months. And the people who got surgery said, gosh, I'm glad I had the surgery. I'm doing pretty well. My pain, from the surgery is getting better. I'm feeling better every day. And they'd report really good outcomes. And the people who only had physical therapy would feel less good about their treatment and would report, well, I'm still having some pain, it's not really all that good. And the studies would show, and did repeatedly show, that the surgery was effective. But then they figured out that you need to do sham surgery trials where people are randomized either to get surgery with physical therapy or to have a sham surgery where they're taken to the operating room, their knee is actually opened up so they end up with a scar, but no one actually does anything to the cartilage. And then those people also get physical therapy, and they figure out who gets better. And as it turns out, in the sham surgery trials, there is no benefit to surgery in those patients. So it may all just be a misclassification of the outcome by the subjects, by the patients in the trial who are assessing their outcome. And now this leads me to the last topic, which is confounding, which is sometimes referred to as confounding bias, but I want to be clear, confounding is not a bias. Confounding is a different phenomenon, and what it is a distortion of the association between exposure and an outcome by a second variable, which is known as the confounder. And for something to be a confounder, it has to both be associated with the exposure of interest in either direction. Either the exposure causes the confounder to happen, or the confounder is more likely to lead to the exposure. But also, the confounder is causally associated with the outcome. So you end up with this triangle. Rather than just having the arrow of exposure leading to outcome, you have this other phenomenon, this other variable, which is represented by the letter C here. And so let's just give a couple of examples. The easiest and simplest example is to imagine the association between living in a house with ashtrays and the development of lung cancer. And I could do a beautiful cohort study where I enroll a really good population of patients who don't have lung cancer at baseline, and I assess whether they live in a house with ashtrays and measure a whole bunch of other things and follow them prospectively over time and really accurately figure out who gets lung cancer and who doesn't. And I'm going to find, I promise you, that living in a house with ashtrays is associated with lung cancer. But as you know, ashtrays don't lead to lung cancer. Cigarettes do. And as it turns out, cigarettes are causally associated with living in a house with ashtrays. If you're a smoker, you need an ashtray, and so smoking leads to ashtrays, and smoking is in fact causally associated with lung cancer. And so the exposure, the association we find between ashtrays and lung cancer is incorrect. It's distorted, because in this particular case, ashtrays have nothing to do with lung cancer. Here's another example. This is an important one. So thinking about obesity and myocardial infarction, because sometimes you can have multiple exposures that can be confounders. So obesity, as it turns out, is in fact associated with heart attacks, with MI, myocardial infarction. But as it turns out, obesity is also associated with a whole range of other things. So hypertension, is associated with being obese and is causally associated with heart attacks, as is high cholesterol, as is diabetes, and sedentary lifestyle. All of those things are associated with obesity and cause heart attacks. So it's hard when we try to measure the true independent impact of obesity on myocardial infarction. It's hard to do that because of all of these confounding variables that distort our accurate assessment of how much individually obesity leads to heart attacks. Now, there's a special, if often we're looking at observational studies of treatments. So one of the first ways we figure out is to look at observational studies of who gets a drug and who doesn't, or who gets surgery and who doesn't, and does that lead to better or worse outcomes. But when we let things happen observationally, where people pick or doctors pick what happens, you can have this phenomenon called confounding by indication, where we have our medical intervention that we're looking at and our outcome, which is hopefully a benefit, some positive treatment outcome. But as it turns out, there's also the indication for the intervention. The reason people have the intervention might be associated with the outcome. So as an example, it might just be that sicker people are given the intervention and less sick people are not, which can lead to a distortion of the association between the outcome, the intervention and the outcome. And a good example of this is early in the AIDS epidemic. The first drug that was available as an antiretroviral drug was something called AZT, and AZT was in observational trials, once it was FDA approved, was being used by doctors mostly for people who had progressed with their HIV illness and were sicker, and that their CD4 counts had dropped, and wasn't given to people early in the illness. And so when you looked at people who were given AZT by their doctors and saw who survived, you found that AZT seemed to be associated with an increased risk of death, because the indication, the reason doctors were picking to give people AZT was actually that they had more severe illness. So it can lead to, again, a distortion. Actually, it turns out AZT works a little bit. Alone, it doesn't work very well, but works quite well in combination with other drugs. And in observational studies, you could miss that. Another really important thing to recognize is when we're studying health behaviors, as it turns out, healthy behaviors cluster a lot. And there are a lot of confounders that happen. So let's say we're looking at eating a healthy diet, say the Mediterranean diet, and its impact on cardiovascular disease. In observational studies of eating a healthy diet, we find that, sure enough, eating a healthy diet is in fact associated with lower risk of heart attack and stroke. Because as it turns out, people who eat a healthy diet are more likely to exercise, and they're actually less likely to smoke. And perhaps more importantly, they're more likely to be affluent, because eating a healthy diet is expensive. So now we've segmented out people eating a healthy diet who tend to be more likely to have insurance and more likely to be able to afford to be on blood pressure pills and on a cholesterol medication and do all those healthy things. And so as it turns out, it's hard to prove in observational studies that actually it's the healthy diet that is what's leading to the reduction in cardiovascular disease, because it might just be all the confounding. And again, remember that this is important. Healthy behaviors cluster a lot, and unhealthy behaviors similarly cluster a lot, for a variety of reasons. And just to be very clear in concluding, the solution to confounding, which is a major problem, is randomization. So the way we get rid of confounding is by doing a randomized controlled trial. And remember, I want to go back, I've said this multiple times in this lecture, all observational studies are affected by confounding. And randomization effectively gets rid of it. Because if we go back to our model of exposure and outcome with a confounder there, when we randomly decide who gets exposed, we effectively break any possible association between any confounder and getting the exposure, because we've decided who gets exposed through an entirely separate process that is random. We don't let patients pick, we don't let doctors pick, and we don't let nature pick who gets exposed. We determine experimentally and randomly. And so that is the solution. And that is how, again, this is why it's the gold standard to figure out if treatments work, because observational studies are always biased by confounding and by biases, and randomized controlled trials at least get rid of confounding, and you can just purely see the relationship between the exposure and the outcome. And let's just use, going back to an example I gave before, if I want to study if vitamin D supplementation is associated with a change in the risk of fractures, I told you before, observational studies show a very clear benefit of vitamin D supplementation leading to a reduction in osteoporotic fractures. But as it turns out, when we do randomized controlled trials, we don't see any benefit for vitamin D. Vitamin D in observational studies, it has been shown to show reduction in cancer, diabetes, infection, depression, fractures, a whole range of things. But when we've done randomized controlled trials of a range of doses of vitamin D, it does not prevent depression, it doesn't prevent cancer, it doesn't prevent cardiovascular disease, it doesn't prevent fractures, it doesn't do any of those things. And it's probably all confounding that leads to the association of vitamin D supplementation and good outcomes in observational studies. So again, remember, you got to do randomized controlled trials before we decide to intervene. That's really, really important. And that is the conclusion of this talk. We will come back more with some in-person lectures where I'll discuss in more detail measurement and a whole range of other things. I hope this has been helpful to you, and I will see you all very soon.